We are live.
Yeah. Yeah. Good evening, everyone, and welcome to the ARC PG webinar. This is the 96th episode, and today our topic is differential diagnosis of white pupillary reflex in kids. Our speaker is Dr. Parag Shah, who is a medical consultant. This is Arvind Hospital, Coimbatore, and our discussants are Dr. Saurav Sinha, who is a vitreoretinal consultant in Kolkata, and Dr. Rohit Dogra, who unfortunately will not be able to attend today. So I'd like to ask Dr. Paraksha to please start his talk.
Thank you, ma'am. So, good evening, everyone. And I would just like to start my talk by offering my sincere condolences, prayers, and thoughts to the families who are affected by the devastated plane crash which we have witnessed today in Ahmedabad. So, I'll be talking on the differential diagnosis of a white pupillary reflex in children, and usually in kids means less than 5 years of age. And I thank Dr. Prashant Bhavankole and the ARC team for giving me this opportunity. And he told me this thing is mainly for the postgraduates to tackle this question, which comes in the exam quite often. And so this exam question can it comes usually in the theory, and it can of course be asked in the practicals also. So how do we approach this a question of a white reflex or the leukocoria? So we can either go unilateral versus bilateral or hereditary versus acquired. But frankly, there's a lot of overlap between these all these things in many diseases. So it becomes quite confusing. Or should we tackle this anatomically, like from anterior to posterior segment? I always tell my postgraduates that if you logically want to answer a question, like if the examiner asks the ocular effects of trauma, if you go from anterior to posterior segment, it's very unlikely that you're going to miss anything or even a side effect of any drug. But then there are some diseases which are not only sight threatening. In ophthalmology, there are these rare diseases which are life threatening also. So obviously, when such diseases come, the life comes before the sight. So we have to think about saving the child's life, obviously, before going to the sight threatening thing. So we'll just go in the and most of this and the most important sight-threatening disease which causes this leukocoria in children comes from the posterior segment. So we can just tackle this uh, question in a reverse gear, starting from the posterior segment to anterior segment. So first we have to know what is the elephant in the room. Elephant in the room is that disease which we just cannot ignore. We have to highlight that, and examiner expects you to tell that what disease is the most important differential diagnosis of a leukocoria. So our institute has only DNB. So I've just taken out last 10 years DNB question bank pertaining to leukocoria in the theory exam. And if you see in this one disease, retinoblastoma, is seen in many of these questions. And even if it is not highlighted, the examiner would expect you to write first about retinoblastoma. So retinoblastoma is the elephant in the room, and you should start tackling this question by writing about retinoblastoma. So when you see a white mass behind pupil in a child, always consider retinoblastoma first, because that is one condition which can actually kill the child. And once you tackle this, then you can go and split into the other sight-threatening posterior segment disorders. Like you can differentiate, I mean, you can divide into sporadic and hereditary. In sporadic, unilateral, bilateral, and you can put as PHPV or PFV, Coats disease, endogenous endophthalmitis. ROP is another very important thing which you should not miss. And in hereditary, which is usually bilateral, but as far as leukocoria is concerned, leukocoria can come only, it can come unilaterally also, but it would be a bilateral disease. The familial exudative vitreoretinopathy, Norrie's disease, and the incontinentia pigmenti. And of course, these are the most important posterior segment diseases. And then you can shift your gear to anterior segment and talk about the most commonest thing is the cataract. Of course, there are other very, very rare tumors like the medullary epithelioma, which happens in the ciliary body. But that's okay. If you don't write about that, if you cover all these things, I think your examiner is going to be quite contented by this. So let's talk a little bit about retinoblastoma. So it's the commonest primary ocular tumor in the childhood. Incidence is around 1 in 15 to 30,000 live births, and it originates from the primitive retinal progenitor cells. Now, the epidemiology, although there are around 8,000 new cases seen world over, almost 25% or 2,000, the highest, are seen in India, followed by China. And why is this more common in India? It's nothing because the population and the birth rate is amongst the highest. Although the population of India is now, this is the recent report which was just published just in the news just a couple of days back, that although the fertility rate has dropped below the replacement level, it is at 1.9, still with a still a huge population and growing still at a very good pace. I think retinoblastoma is still going to be a disease to be taken care for at least for a few couple of more generations of ophthalmologists. So we know that retinoblastoma is a purely genetic disease, and the gene has been identified as the RB1 gene, which is the 13th chromosome on long arm of 13, band 14, and it is a tumor suppressor gene. Means all of us have 13q band 14. Only if it gets mutated or deleted, then there's a risk of developing retinoblastoma. And mind you, both we all have a pair of all the genes, and both the pairs have to be mutated or deleted to cause this disease. And that's the basis of the unilateral or the bilateral. It's called the Knutson's two-hit hypothesis. Two-hit hypothesis means the first hit happens and the second hit happens in the retina. But the timing of the first is very important, which will differentiate between a non-germinal, which is usually a unilateral, from a germinal, which is bilateral. So let's go to unilateral first. When after fertilization, when the child is born, and the first hit happens in a single retinal cell, followed by the second mutation in the same cell, then the child will develop a unilateral or a non-germinal retinoblastoma, which will affect only the retina and is not going to affect the other parts of the body, and it's not going to be genetically transmissible. But if the first hit of the first mutation happens in the father's sperm or the mother's unfertilized ovum, and then after the hit happens, and when the child is born, that means the child is born with one mutation in all the cells of body, which has already been, I mean, the one cell, all the body has been mutated. And when the second mutation happens in the retina, it develops a retinoblastoma. And I mean, a germinal retinoblastoma, which is usually multifocal. And because already all the cells of the body are already mutated, there are risk of second cancers, and they have autosomal dominant thing if they survive, and they have a risk of transmitting to the next generation almost 40 to 50% of the time. And the median age of diagnosis is approximately 18 months. So leukocoria is the most common presentation of retinoblastoma. And unfortunately, when the child comes leukocoria, it's quite a advanced intraocular disease, and nothing much can be done many times to salvage the vision. Although now newer treatments are coming, but still there is no good screening tool to pick up retinoblastoma at an early stage. This is followed by strabismus in 20%, and then defective vision, uveitis, glaucoma, hyphemoproptosis are the rarer types of presentation of retinoblastoma. Other thing the examiner would expect you to write or talk in the practicals is about the calcification on B scan. So if there is a child with a white pupillary reflex and a B scan shows an intraocular mass with calcification, 99% of the 99.9% of the time it has to be retinoblastoma. So that's a very important point which you need to highlight in the exam. Of course, you can write a little bit about the classification of retinoblastoma, the international intraocular retinoblastoma classification, and this is the grouping A, B, C, D, and E. I'm not going to go into much of the details, but A is a very small tumor which is away from the fovea, less than 3 milliliter. B is a little bigger tumor, more than 3 millimeter. C is with the localized vitreous seeds, and D with diffuse, and E is the end-stage disease. So leukocoria, usually the patient comes with a D and E retinoblastoma. These are the various treatment modalities. enucleation with prosthesis is also still offered, and it's still done in many centers, and it is still a very good treatment modality as far as removing the tumor and saving the patient's life is concerned. Of course, you can enumerate the other modalities also of treatment, like the focal treatment, chemotherapy, systemic or intraarterial, and the intravitreal therapy also for the lingering vitreous seeds. So this is for the international classification, retinoblastoma classification. And now we have the AJCC classification. That's nothing but the TNM classification. It looks confusing, but it's quite easy. So we know the TNM classification mainly for all the other oncology affecting the various parts of the body, and they have included H also for heritable thing. And leukocoria usually happens in the T3. The T3 is the advanced intraocular tumor, either D or E, and it's the clinical classification, so it's a CT3. Now, leukocoria, I mean, when we see retinoblastoma, we diagnose as a group C, a group D, or group E, and if the parents are willing for enucleation, we don't require a biopsy to prove that's a retinoblastoma. So when does the uh, uh, benefit of the pathologist come? It is to see after enucleation if they have these high-risk pathology features. Because if after enucleation, if there is massive choroidal invasion, which is invasion of the choroid more than 3 millimeters, or involving of the tumor past the lamina cribrosa, or the tumor invading into the sclera, that means these children have a high risk of distal metastasis, and they require adjuvant chemotherapy after enucleation, at least 6 cycles of systemic chemotherapy. And now the TNM classification, AJCC, has also a pathological arm. P means pathological. And this high-risk pathology features come when the pathologist gives you the PT3. PT3 is significant local invasion. And if this result comes in the pathology, that means the child has a high risk of distant metastasis and will require chemotherapy. So is there a screening tool for retinoblastoma? There is actually, but not as good as we see in other diseases like ROP. So the only screening tool is the distant direct ophthalmoscopy, where you can start as much as early as birth from distance and in a dark room, or some people can even dilate there, but it is done by either a pediatrician or a gynecologist to look at the cat-eye reflex or the leukocoria as seen here. So if this is seen, it does not mean it is always a retinoblastoma. That means it could be a retinoblastoma or it could be any other disease, but this requires a early referral to the ophthalmologist, mainly pediatric ophthalmologist, the retina specialist. So this is just a very short leukocoria awareness video, just to sensitize you all that the leukocoria retinoblastoma is extremely important. And this was actually several years back, projected on the national television of Brazil.
You can tell from a child's eyes if he's happy, when he's sad, frightened, or when he's sleepy. You can tell many things from a child's eyes, including if he's got cancer.
So this was on the national television in Brazil, and after that they got a lot of referrals, and actually we also see a lot of children, a lot of parents come that they had seen a white reflex, but the pediatrician said not to worry and all that, and they ignored it, and when they came, it was a quite advanced disease. So a white reflex in any direction, if the parents say that, it should not be taken lightly.
You can
So now that we have tackled retinoblastoma, let us go to the other sight-threatening posterior segment disorders, like the non-sporadic unilateral. The next thing which I think you should project is the PHPV, or now it's called the PFV. So the PHPV, that means persistent hyperplastic primary vitreous. It's an ocular assembly disorder in which the fetal vasculature does not regress, and it's unilateral 90%. It's non-progressive, but the tractional changes can occur as the child grows. But PHPV is actually a slight misnomer, because when we think about PHPV, we just think about the posterior vitreous. That means just the posterior segment is involved. But actually, the fetal vasculature has two major components, which is the anterior tunica vasculosa lentis and the posterior the hyaloid system. So it's not only the hyaloid system which is affected, the anterior segment also gets affected, and that is why the nomenclature is changed now. Now PHPV is now called as a persistent fetal vasculature, and it is a more precise name because but it can persist the vasculature either in combination or alone. It can be either anterior or posterior or mixed. So the classification of PFP would be three types: anterior, posterior, or the mixed. You can see this anterior with a white reflex behind there. This is the one diagnosed with leukocoria. But it can be a subtle, only a stalk seen going nasally usually in the posterior PFE, or it can be a mixed. Now, when the patient comes with a microphthalmic eye with a opacity, so this would be a differential diagnosis, and there will be the advanced cases. There can be a cataract also, and the diagnostic thing is a retrolental fibrovascular membrane. It can have a shallow AC causing glaucoma, or the elongated process causing hypotony later. And there can be a stalk. It usually is invisible when the child comes with leukocoria, and this is what the examiner would want you to know, that when a B scan comes to the rescue here, it might be a very thin stalk, very subtle, which maybe if you don't look for it, can be missed, or it can be a thick stalk with the tractional little detachment also, with retina also involved. So it can be either of the two. So then it becomes more of a mixed variant. So when it comes with such a leukocoria, microphthalmic eye, of course, the surgery is the treatment of choice, and it's always a dilemma: do you do anterior or posterior? We always think that PHPV is a posterior segment disease, so posterior segment people have to do it. It's actually not so. Many a times it is mainly the anterior segment or just behind the lens. So usually we tell the anterior segment surgeons to tackle it, remove the lens and remove the thick membrane. And if the stalk is there, just cut the stalk and leave it, and usually the bleeding will stop on its own. And if it's and you have to be very careful that if you go in the posterior segment, even if you go a few millimeters behind the limbus, you can easily cause a iatrogenic retinal dialysis, because sometimes the retina comes almost as close as the base of the iris. So this has to be kept in mind. So if you don't see anything in the retina and this is a white reflex, it is safer to go through the anterior segment than to go into the posterior segment. If it's a posterior PFP, it usually will not present as leukocoria. And if it's not in the visual axis, not causing a TRD or anything, you can just leave it and just give a refractive and the amblyopia treatment. So now coming to the next disease is the Coats disease. So Coats disease was first described in 1908 by George Coates, and it is a disease which has the telangiectatic vessels along with the exudation seen, and it is affected more in males, 3 times more. Usually it is unilateral. It could be bilateral. Like I said, all these diseases have some form of overlap, and poor vision, strabismus, and they can present with leukocoria. And this is actually a differential diagnosis for retinoblastoma also, and quite difficult to sometimes differentiate between a BP retinoblastoma from Coats disease. So this is you can talk about a little bit about the modified Shields classification, which was modified in 2017. And this is something like the ROP classification of the stages of ROP, like 1, 2, 3, 4, 5. So 1 would be just telangiectatic vessels. 2 would be telangiectatic vessels with exudation. If it's extrafoveal, it becomes 2A. If it is foveal, it becomes 2B. And presence of nodule is what was added in by Daruch and all in 2017. That B1 is without a nodule at the fovea, and sometimes we see B2 with the nodule, with the fibrotic nodule. That means the visual outcome is going to be extremely poor. If there's a exudatory detachment which is subtotal, it's a 3A. 3B is a total detachment, and 4 is a RD with secondary glaucoma, and 5 is an advanced end-stage disease. So all these things of a 3B to 4 and 5 can present as a leukocoria. And this is the clinical picture. Like you will see exudation around the posterior pole and telangiectatic vessels in the periphery. And if we don't treat this, it can go to a total retinal detachment like this, and then the child will obviously present with the leukocoria with the telangiectatic vessels here. So the treatment is actually usually a green laser photocoagulation, and you just treat the telangiectatic vessel directly with the green laser, like how you do a focal photocoagulation for diabetic retinopathy macular edema. The microaneurysms you hit with your green laser, so that it becomes a little more white or red, and then you stop it. So it's the same fundamental treatment guideline for giving green laser to Coats disease. And of course, there is, if on FFA, if you find CNP areas, you can give a little more scatter laser also. But usually, if you treat the abnormal vessels with the green laser, it usually you have fantastic cure. Cryotherapy was used and can still be used, but the problem with cryotherapy is itself can cause a lot of inflammation and exudation can actually increase. So cryotherapy is not favored much. The green laser is not, and even on a detached retina, you can give green laser on those red blood vessels. And in severe cases, of course, in leukocoria, you can do a surgery, subretinal fluid drainage, and do the laser once the retina settles. Now, coming to the next important sporadic is endogenous endophthalmitis and unilateral, but we have seen cases with bilateral endogenous endophthalmitis also. And it is quite rare, but it's a highly destructive thing if it happens especially in babies. And obviously the pathogenic organisms reach through the systemic circulation, and the source is usually a distant wound infection. We've seen in the children in the NICU getting an infection on the IV line, IV catheters. We had a case of fungal meningitis presenting as endophthalmitis, and of course endocarditis and UTI also. So streptococcus and staphylococcus are the most common, and Canada also is not very rare, and Pseudomonas also we have seen. So the treatment again is a B scan, of course, because it's a systemic, comes to the systemic route. You have to do blood cultures and give systemic and topical antibiotics and vitreous tap culturing and intravitreal antibiotics and core vitrectomy would be the treatment of choice for these babies. Now coming to the bilateral sporadic, and the most important thing is disease is the retinopathy of prematurity. Now, retinopathy of prematurity is, it's a vasoproliferative disorder occurring only in preterm babies due to defective vasculogenesis. Now, and it's an avoidable cause of childhood blindness. In fact, it's the most common avoidable childhood blindness currently throughout the world. And why does it happen only in preterm babies? Now, this was actually asked in the previous DNB OSCEs also, that when does the blood vessels reach nasally and when do they reach temporally? So a full-term baby is 40 weeks. So obviously when a full-term baby is born, usually the retina is almost fully vascularized, and that is why they don't have any risk of developing ROP. But as the child is born more prematurely, the lesser the gestational age, the larger the avascular retina and the higher the risk of ROP. And if the gestational age is less, obviously the corresponding birth weight also will be less. So gestational and age and the birth weight are the most important risk factors for ROP. And that is where all the screening guidelines also revolve. They have the cutoff for gestation and birth weight. And timely screening, usually 4 weeks after birth, is extremely important. Avoid blindness. And blindness means stage 5 means leukocoria. You can quickly enumerate the stages of ROP. You don't have to give the entire classification. And you can just say that stage 1 demarcation line, stage 2 is ridge, stage 3 is the extraretinal fibrovascular proliferation, stage 4 is a partial retinal detachment, extrafoveal A and B is involving fovea. And leukocoria comes at the total stage 5 detachment. And the new ICROP3 classification, which is published in 2021, they have subdivided stage 5 ROP into 3 types, A, B, and C. A is when the posterior pole, the disc is seen. That means it's an open funnel. You don't require an ultrasound to tell you that it's open funnel. Clinically, you can make out. But if you can't see the disc, and if you just see a retrodental fibrous tissue, then that means it's a 5B. It's a closed funnel detachment. And if it's a long-standing one, it will have a shallow anterior chamber. It will have funnel opacities because of the adhesion of the lens with the pushing of the lens anteriorly. And if you find anterior segment changes with a total retinal detachment, then it becomes a stage 5C ROP. And these are the pictures, these are figures which I've taken from the ICROP3. This is the 5A ROP. This is the stage 5B, and this is the stage 5C shallow anterior chamber with the sort of adherent leukoma. Of course, treatment at this stage is the visual prognosis is extremely poor, and it's lensectomy and vitrectomy. But the whole idea of highlighting this, that we should avoid children coming to this late stage of ROP, because this is a total preventable cause of childhood blindness if early. Now, coming to the next side is the hereditary diseases, usually bilateral. Like I said, bilateral doesn't mean that leukocoria will come bilateral. ROP also, it doesn't mean the leukocoria stage 5 can always happen bilaterally. It can happen stage 5 in one eye, and a regressed ROP or a 4A or 4B in the other eye. So coming to FEVR, so FEVR is again a proliferative vascular diseases where there's a genetic disease. The retinal vessels fail to grow in the far periphery, and it is called the ROP of term babies. And why is it? Because it looks very similar to ROP, but there is no history of any prematurity or any oxygen given. These are all full-term babies. So if you see a full-term baby or a child who is not born prematurely, and if you see with leukocoria or even like a 4B or a 4A ROP, you must think of other diseases like a CVR. And it's usually an autosomal dominant disease. So family screening becomes very important. Like, and I forgot to mention, even retinoblastoma, family screening is extremely important because you can pick up if the parents or someone else in the family are the carriers. And rarely it can be an X-linked recessive or an autosomal recessive also. Again, the classification of FEVR, you can just enumerate it if you can remember. Again, it's like the stages of stage 5, like an ROP 1, 2, 3, 4, 5. A is a avascular retina, and this was modified by Kashani on FFA, where you can see leakage. So if it's only avascular retina without exudates leakage, it's for 1A. 1B is with exudates leakage. So AB is common without exudates and with exudates or leakage in all the 4 stages. So if avascular retina is stage 1, avascular retina with NVE, with exudates, without exudates or leakage, AB. The partial little detachment not involved in the fovea is stage 3. Again, 3AB is with exudates, without exudates, and with exudates. And stage 4 is a partial little detachment without exudates and with exudates. And stage 5 is the leukocoria, when it's a total detachment, either open funnel or a closed funnel on ultrasound. And of course, the treatment here is laser photocoagulation, but at stage 5 FEVR, the visual outcome is the visual progress is very less. Now, going to the last, these 2 posterior segment important diseases, the Norrie disease, incontinentia pigmenti. And the way to remember here is Norrie's happens only in males and incontinentia happens only in females. And why is that? Because Norrie is a X-linked recessive disease. So only the males can be affected. The mutation is the NDP gene. And it's usually with bilateral retinoblastoma. There won't be any history of prematurity. It's a dysplastic retina and blindness from birth. If you try surgeries also, we have tried, but the visual outcome is extremely poor. But they have some systemic implications, especially there will be sensory neural hearing loss. And that would be one of the key things, that if you have a child who has bilateral leukocoria, bilateral RD, deafness, you must think of a male child, you must think of the Norrie's disease. And you can do a genetic analysis also, which is available in India. And you can test, usually the mother is a carrier, and just checks the mother also. And we have find families where the mother was affected and was not presenting with the disease. Because obviously female have 2 X chromosomes, so the recessive will not come to there. Unlike incontinentia pigmenti, incontinentia pigmenti is a X-linked dominant disease, so it can happen only in females because the males will never survive with this dominant mutation. And what is the characteristic thing? The most ghastly thing which we see at birth are these abnormal skin lesions, which happen in all the 4 extremities. And it's a female child, so it's usually, again, it is sort of not a misnomer, but incontinentia pigmenti means we think it's a disease of the skin. It is a disease of the skin, but it's not that sight threatening or life threatening. The skin lesions will go off within a few months' time, and nothing will be seen. But if eyes are not checked, there is a very high chance that the child can end up with a total little detachment leukocoria, like a stage 5 ROP. So it's very important that dermatologists, pediatricians pick up the disease and they refer to the ophthalmologist to see, because they can have avascular retina like FEVR at stages of ROP, like a stage 3 ROP. And if we don't treat it by laser or anti-VEGF, laser would be the thing, then these children are at the risk of going totally blind. Of course, then you can go on other diseases like the trauma. Trauma also can cause leukocoria, and congenital cataracts. It's an anterior segment disease. And I mean, you can keep on writing this answer, and there is no end to it, because even the congenital cataracts, it can be unilateral, it can be bilateral. I mean, it can be a congenital, it can be sporadic. I mean, this thing. And but one thing you should remember, that in the exam, especially in the theory exam, the clock is ticking. So what you need to do is you have to have your common sense and presence of mind is when should you stop writing the answer. So I always tell my postgraduates in the DNB exam, it's very simple mathematics. There are going to be 10 questions in 180 minutes. So you have approximately 18 minutes to tackle each answer. But I would say like 15 minutes you should stop. Just because you know something more or you can write more, you should not overshoot the time. And of course, in DNB, there is a space constraint also. Nobody can write more than 5 pages because after the 5 pages, the next question is already printed, the number. So there is a time and the space. So you should have that in mind. Keep it aware. Just enumerate and write something about all the important diseases and in the question. So with this, I'd just like to end the talk by saying that when you see a white mass behind pupil, always consider retinoblastoma. Tackle retinoblastoma, write something about retinoblastoma first, and then you can go to the posterior segment disorders. If you can write about, and of course, retinoblastoma is the elephant in the room. So don't forget about that. Write a little bit about PHPV or the PFV, Coats disease, ROP. Again, a very important thing, you should not forget mentioning about ROP in a case of leukocoria. And if you can write a little bit of a FEVR and of course a little bit of congenital cataracts, I think the examiner is going to be extremely happy, be it your theory exam or your practicals. And I think he'll be very happy to give you at least good marks. So thank you very much.
Yeah, this is a scale.
Extremely lucid and extremely detailed talk, Dr. Parag. Very, very nicely covered. Now, I'd like to request the discussants also to give their views. Dr. Sinha, Dr. Vijeta, can we have the cameras on, please? Yeah, yeah. Yes, yes.
Yeah, thanks,
Yeah.
Dr. Parag. I agree with Dr. Anaka. It's like very concise and still like covers everything from both an exam and a passing out general ophthalmologist viewpoint. Dr. Saurabh, do you want to go first? And then maybe I can add a little bit on the RB if
You
that's
go
okay.
ahead. You go ahead. So, unfortunately, I'm the old guy over here. So, so okay. I have a few points. Parag, hats off to you. Job well done. So, for my years at SN and now at a private practice, few points and few mistakes that I made over the years. Quickly, for anybody listening in, if you see a child 3-4 years with panophthalmitis, be very aware. You can't open the eyelid, child crying, mother crying, grandparents crying. Be very aware, not to say it's panoff. It could be an RB with extension. What Parag was hammering again, RB. It could be RB with extension. I made this mistake 20 years, 16 years, 18 years back of saying, okay, I'll do evisceration. And when I took the child to the OT and under G, I opened and I said, oh, bloody hell. It was RB. So any child with panophthalmitis, be very, very careful. Endogenous, whatever it is, see, I will put an anesthesia and I'll take a call what I see at that time. So PANOF is not a diagnosis for a 5-year-old. There's something underlying over there. 1. 2. Any child that you cannot see anything at all, not sure, again, I insist, child crying, mother crying, grandparents crying, say I will do a UA, examination under anesthesia. I think that's very important. Do not commit anything at all, get a UA done. Third, any child you don't know what the hell is happening, child crying, mother crying, say I will do an ultrasound, see what's happening. Sometimes very rare, you can't get the child to open the eye, no OPD, child eyes slippery, watering, this, that. You have a busy OPD, say at least get an ultrasound done. You may or may not get something at all. 2. Any child with one eye disease, whatever it is, RB, what a Parag said, all the diagnosis, I agree with everything. Tell them I will check the other eye under UA. Why do you want to put an GA? No, GA is so difficult. All those things. Say I want to examine the other eye very carefully to see what's there over there. So that's how you convince the parents. You want to see what's happening this eye and you want to see the other eye is fine or not. It's very important that they will accept your wish to do an examination under anesthesia. All congenital cataracts you need ultrasound. Wherever you are, however peripheral you are, whatever you are doing, Lions Hospital, whatever you are doing, free surgeries, free things, need an ultrasound. You cannot do an conjugal cataract surgery for a child, for a baby, without doing ultrasound. And you should teach your optometrists, your assistants, that any child coming in, just take a history of his prematurity as a routine. Severe myopia, conjugal cataract, whatever it is, they should be the habit of taking history of prematurity. Like Parag said, that's the giveaway sign for ROP or whatever, Norrie, whatever it is. It gives us a lot of diagnosis. One more now, why I'm saying this is because the nucleation I did around 22 years ago. Child comes back now and the parents say, Shadi karana, Marwadi people, Shadi karana. I'm like, Are yaar, bacha hai, 22 saal ka hai. They say, no. You have included one eye 22 years ago because of RB. Now we want a child getting married. What is the chance of his child getting it? So it's extremely important that we look at genetics very, as all ophthalmologists, it's available in multiple centers all over the country. So we say, I don't know, go see the genetics person. Don't take a decision yourself. I think it's very important. Few practical points from my side. Please go ahead.
So very good point, sir. I totally agree that examination anesthesia is extremely important. Just because it's a child, everybody's crying. It's a very sort of a in the OPD, it becomes a white sort of a ruckus like thing, and then they think that what are you doing? You're not doing anything. I said, no, I can't do anything because I need to examine the child. And like you said, the other eye and the B scan is extremely important to pick up this. And even we have seen cases with congenital glaucoma taken by the glaucoma surgery, and it turned out to be actually a retinoblastoma.
I've done that also. Believe me, I've been through that also. All the mistakes that you were talking about, I've made that right now. So my exactly what Parag said, that even glaucoma, ophthalmos missed it on OPD. You thought you were a big guy doing on it, and nothing happened. I agree with him wholeheartedly. Vijita, please go ahead.
Yeah, Dr. Vijayka.
Yeah, so like very relevant points by Dr. Sinha. Agree with all of them, starting with if we cannot see the child, there's no harm, but you can always almost do a B scan in OPD, even if it's an older child. However, not cooperative, B scan is usually feasible. And even from medical legal standpoint, I would say it should be there, like in your clinic. And yes, EUA for all children with suspected retinoblastoma, because sometimes we may not be able to see the eye for which they're presenting to us, but you may save the other eye because by picking up a much smaller tumor. And also, as mentioned, screening the parents and asking history about their siblings is also very important. That's from history standpoint. And so like approaching the question from that viewpoint, whether be it a theory or if it's posed to you during your viva, one way of listing of what all you think of and how you can lead your examiner is also that you can start with the most common cause is, and go in that order, and then eventually come to retinoblastoma. Or that is also one approach which the examiners like, and it's you're not pushing them to something which you don't know much about. Say you don't know really about FEVR and Norrie's disease, you don't want to put that in the first differential. Another systematic way of listing things, which is also good when you write down an answer, is you put them as congenital causes, vascular causes, tumors, traumas, and infection. This is usually the case for any disease, and you're unlikely to forget that. And then you can actually flag among these which is most common. And of course, like if you have a footnote that although retinoblastoma is not the most common of these, but it's the most grave among these, and has to be evaluated, and you can take the answer on those lines. And so about what to write for RB was, like, I would say, mostly comprehensive. I just have a couple of points to add. So if at all someone takes you to genetics and then they were to ask you about unilateral and bilateral, those percentages are good to remember. But it's also important that Most often, it's not that the gene is inherited from either the mother or father, but a de novo mutation can occur in utero. So that's one caveat. Even though, like we call it hereditary, it's not necessary that it's always passed on from the parents. And about describing the clinical features, yes, A, B, C, D, E, I'm sure that'll make the examiner happy. But you must also remember what Dr. Saurav Sinha has mentioned, that extraocular is also one grave aspect of it. It's good to make a mention that it can spread either by the optic nerve or through the sclera into the orbit. And either of, even whether these are present or not present, they can still have orbital inflammation. That's usually the advanced stage in the AGCC CT3, which Dr. Parag has shown. And so any cellulitis in a child or an adult, it's not a diagnosis by itself. So if you have that concept, then this will fall in place. It has to be because of something. So in children, it's usually due to an eyelid stye or sinusitis in older children, or sometimes because of NLDO. So your history can also give you a clue to where this has led to. And one important aspect is that you can always add review of photographs. Like if it's more like a viva and it's going in this direction, you can always review photographs. Nowadays, all parents have smartphones, and you can look back and check if they had a white reflex at all, and you might be the first one to pick it up and as well. And we talked about B-scan and EUA being a must. And from a management standpoint, one more thing which becomes important is the MRI also. So if you were to be asked, like, which is the preferred modality for imaging and ruling out extraocular extension or identifying if there are any high risk features, especially when you see children with pseudocellulitis, you will have to say MRI. Earlier days, especially when it was not so commonly available, CT and the textbook description of calcification is also mentioned. But given the possibility of them having a heritable disease, and subjecting them to radiation is like not the best recommended practice. So it would be MRI to determine extraocular or optic nerve extension, and of course the brain also through the sections that you get. And pathology is extremely important. I do know like that some people like this question of, okay, if it's unilateral and it's enucleated, what do you do with the child next? So you have to go up and say, we look at the pathology and look at these risk factors like massive choroidal invasion and optic nerve invasion, in which case they'll require adjuvant chemotherapy. And from a treatment, what all treatments are there, that was also very nicely described by Dr. Parag in the flow chart. Only I would add that there is still a role of radiotherapy, especially for extraocular disease in the form of EBRT, or for recurrent diseases as in plaque radiotherapy. That would probably be like a bonus if you could mention it. And yeah, and siblings screening is especially important. Going ahead, if they were to ask you, like you see an older patient who's been treated for RB and she's 25 years old, what would you do next? Then would be like counseling about heritability of the disease and genetic testing. And I'm not sure like if it would be really under DNB or MS purview as of now, but pre-implantation genetic diagnosis is something that is quite popular, at least in the West, and it is increasing becoming popular in India also, although not so much for retinoblastoma. But as Dr. Parag has shown that we're only going to have like more survivors, and that means like they're going to be like the next generation that we'll be seeing very soon. So that's a good thing to keep in mind. Yeah, that's everything I had.
Great, great. I think excellent inputs from everyone. I think definitely our PGs are going to benefit from all these discussions. And now they would probably wait for this question to come so
Yeah,
that they
that
can
would be
crack
the
it.
first differential then.
Yes. So they'll
Oh,
probably
and
choose this question.
Right. So I remember that even pathology of retinoblastoma used to be like one of the important parts.
Question.
So that would be like you mentioned the round blue cell tumor and rosettes, which are typical, which are flexnum intestina, humorite, and pseudo rosettes around the blood vessel. Yeah, that's pretty much. So one short,
Yeah.
I mean, for DNB it's all the same, but in different universities they have short questions also. That's kind of a short question for in
Right.
RB.
Right. So excellent discussion. Any other points, Dr. Parag? Would you like to add anything?
No, I think all the points were very well discussed by both
Yeah.
Dr. Vijeta and Dr. Saurasena. And yeah, I mean, genetics and all is all extremely important. Genetic testing is available now. Pre-implantation genetic
Right.
diagnosis also is available. Unfortunately, our patients are quite poor. They cannot afford.
Yeah,
It
so I was
can
about to
it
ask
can be done.
that for the
Yeah.
benefits of the viewers, what is the usual costing of the test, genetic test?
No, the genetic testing is now it's done in Arvind Eye Hospital, Madurai, at the cost of 16,000 rupees for the proband. And if the mutation is found, then each family member, which costs 1,000 rupees. So if it's a nuclear family, around 18,000 rupees it will be done. And we have done not pre-implantation, but prenatal genetic diagnosis, where
Mm,
Korean syphilis biopsy was done at 10 weeks of gestation when the mutation is known. And so the parents, these are young couples, they would want to continue the family, second child. So we had found the mutation on the fetus. The parents went ahead with the pregnancy. Because the child was a carrier, we started screening from birth, and very small tumors, we started doing laser, and that's why we could save the child's eye and the vision without giving any chemotherapy. So even pre-implantation is very much there. Another thing, latest thing, which is now is the liquid biopsy. It's like nothing but the aqueous tap where you can do a cell-free DNA testing, and it is now available. It's all available in India, and I'm sure the next generation of postgraduates is going to be quite exciting for them with all these new modalities which are there and which they can really try and help the patients.
so true. Thank you so much, Dr. Parag,
Mm.
for a lovely presentation. And thank you so much, Dr. Sinha sir, Dr. Vijeta ma'am, for sparing your valuable time and joining us at ARC for this AIOS ARC webinar. And I think all our postgraduates with all these PG programs definitely benefit so much. And I think not just PGs, even for practicing ophthalmologists, this is a very good revision of all these topics. So thank you so much, everyone.
If I may, I appreciate your dedication, being on a train and joining us. Hats off to you. Job well done. Thank you so much. We need more
Thank
people
you.
like you.
Thank you, sir. Sorry, I was actually getting down the train when I was talking. So, and there was a lot of crowd. I was hoping the mobile doesn't fall off my hand.
Well done.
Sorry.
God bless you.
Thank you.
God bless you.
Thank you so much. Thank
Thank
you
you so
so
much,
much,
everyone.
everyone. Thank
Thank you.
you.
Hey, say
Thank
hi to Rajiv, please.
Sure,
you.
sure. I
Take care.
Thank you.
Thank
Parag,
you.
thank you so much. Good job.
Thank you,
Thank
sir.
you so
Thank
much.
you.
Thank you
Thank
so
you.
much, sir.
Thanks.
Great.
Okay.
Yeah.
Bye bye.
Thanks
Thank
to our
Good night.
support admin also. Thank you.